in global surgery, which is very topical at the moment. So I think it'd be really nice to hear from everyone, hear from our speakers, and then of course have a good discussion at the end. We will be admitting people as we continue, but I think we'll just get started by introducing everyone here today. So just for those of you who aren't familiar yet, the PGSSC is our Harvard branch of the Paul Farmer Collaborative, which works in conjunction with the Center for Equity and Global Surgery at UGHE. And together, the Paul Farmer Collaborative does a set of research activities, but this particular activity is related to the research seminar, which is a five-session series exploring the methods and outcomes on global surgery research. We tend to have 2 to 3 speakers every month who talk on similar topics or methods, and then we have a discussion about the results and implications and methods at the end. There's lots more information available on our website, and I will post the videos up there later as well. And you should have access to that because I will send that around again at the end. So this is our coordinating team. They do a really good job and work really hard to put on this set of seminars for you all. So it's coordinated primarily by Dr. Boatin and Dr. Hetgothier at HMS in conjunction with Dr. Perrett at CEGS, and then works closely with myself, Taylor, Alex, and Sarah, who are some of the fellows amongst those 2 institutions. Today we have 3 speakers, and again, I'm really excited about all of them. To start introductions, I'll start with Dr. Navarro. So Dr. Navarro graduated with a Bachelor of Science in Mechanical Engineering and a Bachelor of Science in Ancient and Medieval Studies from the Massachusetts Institute of Technology. He subsequently worked in industry in advanced data analysis and risk management in New York City.
You're going to have a lot of echoes.
Oh, you guys hear me? I'll continue. Before pursuing a medical degree at the Baylor College of Medicine, focusing on global health innovation and machine learning data analysis, and has more than 100 peer-reviewed publications and presentations. He also received a master's degree in business administration at Trinity College at the University of Oxford, studying the strategy of surgical innovation. As a resident physician at the University of Minnesota and now currently a research fellow at the Mayo Clinic, Rochester, his focus on innovation in investigating surgical disparities, global surgical collaboration, and risk modeling to evaluate trauma patient care. He is currently completing the Stimulating Access to Research in Residency program at the Mayo Clinic under the mentorship of trauma surgeon and critical care physician Myung S. Park, a world-leading expert on venous thrombosis in trauma, and is applying artificial intelligence to predict patients at high risk of venous thromboembolism after traumatic injury. He is helping lead multiple clinical trials to improve care of traumatic coagulopathy and venous thromboembolism in trauma. We also have Alice Umatomi and Ms. Dadson. So Alice Umatomi is a Global Surgery Fellow at Operation Smile International and an MSc at the University of Global Health Equity on the track of global surgery. She's an aspiring plastic surgeon and global surgery leader. She's the co-founder and current president of Afro-PRS. At Operation Smile, she works closely with the Department of Policy and Advocacy to facilitate development of national surgical obstetric anesthetic plans in Rwanda, with a successful midterm review of the Rwanda ENSOP in 2018-2024. She was an editorial intern with the Annals of African Surgery in 2022-2023, which is affiliated with the University of Nairobi, where she has reviewed 21 submitted manuscripts. She has co-authored several peer-reviewed manuscripts on different topics: pediatric burns, healthcare policy, global surgery, patient perspective, and systematic reviews, with an ambition to address challenges and an advocate for proper surgical care, safety, and access in low and middle-income countries, especially in sub-Saharan Africa with evidence-based solutions. Her growth and career of becoming a medical doctor with ambitions have been shaped throughout mentorship, which equipped with essential skills. She's looking forward to becoming a mentor to the girls and women who wish to follow their dreams. Shirley Sarah Dadson is a medical student at the University of Ghana Medical School. She's passionate about healthcare innovation and plastic and reconstructive surgery. A speaker at events like the 24th CATHEXA conference, she actively promotes collaboration, education, and transformative healthcare solutions across the continent. As the Vice President of Afro-PRS, she empowers the next generation of African plastic and reconstructive surgeons throughout mentorship, education, and advocacy, focusing on research visibility, safe surgical care, and community building initiatives. So with that, what we'll do is I will hand over to Dr. Navarro, who'll be speaking on his paper, Identifying New Frontiers for Social Media Engagement in Global Surgery, an Observational Study.
Thank you, Afra, for the lovely introduction. Now I'll share my screen. And I'd like to thank the PGSSC and the CEGS for inviting me to share a little bit about our paper today. Without further ado, we'll get started. I have no disclosures. In our study, we sought to answer the question, in a world of increasing social media usage, what does the ecosystem of global surgery and social media look like? And at the time we were asking the question in 2019, we had noted a dramatic increase in the number of people using social media platforms. From 2004 to 2018, the amount of daily users of Facebook, YouTube, WhatsApp, WeChat, Instagram had increased from 0 to nearly 2 billion for Facebook, 1.9 million for YouTube, and over nearly 1.5 billion for WhatsApp users. And so we tried to answer the question, what did that mean for global surgery and how we communicate in a world where we are able to share information and share knowledge with a single touch of a button? And we sought to define what that looked like. There is supposed to be a video that will play. And really seeing who are the people that are interacting on a daily basis and what is being shared and what's the content. And so we developed a team informally of global surgical Student Surgery Alliance members, as well as Incision, COSEXA, and the Oxford University Global Surgery Group members. And these are a few of the associations and based on our relationships and friendships and partnerships that have been developed. And would like to thank all the co-authors, but some of the co-authors included Evan Keel and Connor Dedeker from the University of Minnesota, Dennis Mazingi from Zimbabwe, now at Oxford University, Andale Dube, who is at the Zim National University of Science and Technology, also now at Oxford University, and Kelsey Stewart, who's at Mayo Clinic. And then also some of the mentors that we discussed this project with and got their feedback and buy-in on were Jennifer Ricard, Todd Tuttle, Chris Lavi, and Tando Nakube, who was in South Africa at the time, but is now in Zimbabwe. And once we had that team and that idea, we tried to develop our methods. And we really wanted to answer the question, the who, the what, the where, and how for social media and global surgery. Who's posting about global surgery? What are they posting about? When are they posting? And what for? What's the purpose? And so we conducted a time-based analysis of social media posts related to global surgery on two major public platforms, Twitter at the time, now X, and Instagram. And so this was more than 2,000 posts that we analyzed over a 3-month period. And we really nailed down a single hashtag search based on global surgery. This was only based in English, and we used Excel and we data scraped from the websites directly. But we also validated that information using a SEO or a social media analytics tool called Simpler that we got a free trial from. And then we also used a demo trial of ArcGIS to map where in the world that data was coming from and those social media posts were coming from. We didn't require any funding because we relied on Excel, brute force, and demo trials. And we were exempted for IRB approval because we were only using publicly available content that was not patient sensitive. And what we found was that global surgery and global surgery postings were global across Instagram and Twitter, or X. And there were certain areas that were more predominant than others. So the US and the UK were more predominant posters. However, there's a broad distribution geographically globally, including in Africa, in sub-Saharan Africa. We also found that postings by physicians at 73% and professional organizations at 19% predominated. And that's the majority of postings. There were some postings by businesses, and there were some postings by friends, patients, and family, but those were dwarfed by physician and individual postings. And then finally, content revolved around public awareness at 41%, as well as educational content about global surgery, and then advertising for seminars, webinars, or conferences at 19%. And research composed another 16%. So all in all, our main takeaway, however, was that the global surgery conversation was driven by influencers, and 1/5 of posters comprised about 2/3 of posts both on Instagram and Twitter. And it was interesting. The breakdown was similar between Instagram and Twitter. And so the 1% was posting either 13% or 25% of the content, and the 20% was posting about 2/3 of the content. So there were definitely influencers at play or major players in terms of the conversation and narrative. And so what does this mean for global surgery? Is that global surgery was indeed global when we looked at it, and that everybody was participating in the daily conversations on Twitter and Instagram. However, so many influencers certainly dominated some of the narratives and the content posting. And so the so many influencers were posting about 7 to 8 times a day on global surgery topics on average. And so solutions to increase the amount of equity, the distribution, and so our co-authors and our mentors, we felt that a more equitable representation of global surgery could be promoted. And when we looked at what potential solutions existed, we saw that effective usage of social media networks and collaboratives could promote and increase equitable engagement. And so Surge Africa, for example, had created a WhatsApp group that maybe some of you on this call are a part of. There was also a social media network, the Thoracic Surgery Social Media Network, and they created a leadership campaign as well as network campaign to be able to post content and increase membership for posting on social media. And then Incision has played a large role in increasing the spread of content and dissemination of information about global surgery globally. And so the Incision networks have been really instrumental to increasing the equitability of social media about global surgery. So that is all I had for today's topic. I have a couple of appendix slides that I can share some of our learning points or future points of research that I can, after I think we have a little bit of time, so I could go into briefly if that's okay. And so one of the things that we really learned was how to effectively conduct research on a shoestring budget. We had no funding, we had no money. And so what we did is, in order to develop our research, we developed a research question. What does the landscape look like for social media? Then we formulated our methodology and search strategy. We picked a single hashtag, global surgery. We looked at 10 other hashtags and we did an analysis to see, does SOMI surgery, are there other topics, for example, tropical medicine, where they were touching on global surgery topics. But after reviewing the data from a pilot study with our mentors, we agreed on our search strategy. And then we recruited a really solid team that was global. And so that, in addition to our demos, securing low cost and free resources, ensuring buy-in from our mentorship team, made a successful project. Future work is developing or improving coverage of content and search terms. So we limited our analysis to a single hashtag to the English language, and we recognize that global surgery is not just in English; it can be in a multitude of languages. We also limited our study to 2 major social media platforms, and as many of you know, there are a lot of other networks and platforms available today, 5-6 years from now, in LinkedIn and TikTok, where there could be additional work and analysis. And our analysis was based on the country of the posting account. So future work could expand to more advanced SEO analytics, capturing engagement, influence, perceptions, as well as bridge with the other aforementioned platforms and branch across languages. And then our analysis was conducted over a 3-month time period. And so we have the potential to conduct analysis over a longer time scale to evaluate periodicity and growth trends. Some of these blips in posting were linked to major conferences about global surgery. So global surgery conferences. And so looking at over a larger time scale, you could capture growth. You could also capture seasonality. And then I'll finally touch on some of our ongoing work. And so I really want to thank this group for having this this webinar and seminar series, because now is more than ever a time to get involved in global surgery. Global health and global surgery is at risk. And as Al-Kire published in 2019, 70% of the world lacks access to safe surgery. And this is at threat right now. So regardless of whether you have funding, if you're a medical student or you're a resident or you're faculty, you can get involved in global surgery research if you have the right methods, if you're asking the right questions. So I'm so glad that we have a really great audience today, and we can that believe in this purpose. So what we're trying to do here is understand how medical students and residents can better engage in global surgery research. So this was one of our studies that we recently published on medical student perceptions of clinic and research training. And we're looking at what are some of the barriers to conducting research at the medical student level. Some of that is access to literature, being able to afford to attend conferences globally. We're also examining the impact of artificial intelligence and precision medicine in global surgery for data curation, as well as predictive artificial intelligence and generative artificial intelligence in global surgery. And then finally, we're advocating for global surgery and global health in a rapidly changing funding landscape. And so some of the solutions that we think are sustainable are innovation, cheap innovation, or frugal innovation, expanding global partnerships and collaborations like we talked about today, and then looking at alternate funding vehicles like impact investment and the Global Surgery Foundation, for example. That's all I have. Thank you. I'll take any questions.
Thank you very much. We'll do questions at the end. I think once we'll head from our second set of speakers, we can do a discussion as a group. Thank you very much for presenting that. So I will hand over to Alice and Shirley, who I think are presenting next, and they're co-presenting on the paper Assessing the Reliability of YouTube Content Plastic Surgery Patient Information in Africa with the Modified Discern and JAMA skill set.
Let me share my slides. Facing a little bit of the trouble. Let me. Hi, good morning, good afternoon, and good evening. And so thank you so much to the PGSSC program to give us the opportunity to be on the same panel, talking about like surgery, global surgery, and social media. So our study, we assessed the reliability of YouTube content for plastic surgery patient information in Africa using 2 scores, modified Discern and JAMA scores. So I and my colleagues, we are not only the 2 people, I think we are around 11 people on this study, but we collaborated through a research department at the Association of Future African Plastic and Reconstructive Surgeons. And it all started as an idea. So I'm also affiliated to Operation Smile and also now to Global Health Equity. So in July, there has been I think like probably I have wanted to become a plastic surgeon. So when you want to do that, then you hear news and you want to comment about it. So because I'm involved into policy and advocacy work, so I know how to write op-eds and also comment about like international news or local news. So in July 4th, I commented about one of the uh, like Nigerian artists that was dead due to Brazilian bad lift, and she went through the surgery via a non-certified plastic surgeon within the country. So I published a paper through Global Health Unfiltered. I think most of you might know that outlet. So it is where I mentioned about that there's some complexity about plastic surgery that we need to enhance beauty, but in a safer way. So after that publication, then I talked to one of my mentors, Yurik Simi, and at the same time, she was also talking about that. And Rick, as he always does, he just connects people and then big projects start to happen. So in July 28th, we published something else again in the Global Health and Field about Association of Future Plastic Reconstructive Surgeons, where we're talking about the nuclear plastic surgery and
With your sound, maybe it's a little fuzzy at the moment.
oh, probably you can't hear me quite well.
But now it's much better.
Yeah, I have a background sound because there are airplanes flying over me. So I'm sorry about that. So in maybe I will include a voice if that helps. So in July, like 28, we released another op-ed about the plastic surgery and a new way of doing that because we thought that plastic surgery was kind of a hit, like one of those specialties where you know what you want to do when you're in it, and we wanted to expose people to plastic surgery, like content and also advocacy while they were still medical students. So within this association, we are now over 150 something of African people coming in more than 15 African countries. So that association is fully non-funded. It just from your own will, you take probably a certain kind of a position, and then you also start participating in research courses. So we have done apparently more than 5 researches that are all fully non-funded because we mostly do surveys and also open data. So after that, we released an editorial in the Annals of Plastic Surgery about building the next generation of African plastic surgeons, and we have all our like course artwork within this editorial. So my question is, so why is there a need to assess the reliability of YouTube content for plastic surgery patient information? So plastic surgery is one of those specialty or some of those like procedures that you would want to see an outcome before you even try it, especially if it is cosmetic surgery. So we found that there might be certain kind of content that African people are exposed to, and we wanted to assess the reliability because there has been a trend, especially during COVID, where people started now to have low self-esteem. And if you remember, most of the like the content, social media content in COVID, they were practically people making up like all the makeups, changing clothes. So people had like a lot of time of self-reflection, and through that we saw an increase into like plastic surgery content coming up. I don't know if it is the algorithm, but mine was mostly about like new makeup, what you can order online, how you can change it. So I don't know. And so we saw that it was needed to assess the reliability and of African content. And if you don't know, depending on your VPN, we are all exposed to different content. So if I search a video when I'm in Rwanda, it is different results when you're doing that in the US. So when we are trying to do this study, I started with this idea of plastic surgery content in general, and then also the next idea was to see what content do cleft people or cleft patients are exposed to if you compare Africans and also the United States. But due to lack of people to corroborate, I did not get like a VPN or videos from the US, so I just dropped the idea and then we focused on this one. So I wanted to mention about like YouTube is the second most visited site globally, and it hosts over 5 billion videos and nearly 3 billion subscribers. And if I would ask who haven't searched any health information on Google, either ChatGPT, now DeepSeek, everything. So I think like most of you would have searched at least one information, or you would have called one of your friends who is a doctor and you didn't go to consult like in a more consultation. So 80% of individuals use internet and mainly YouTube before consultation. So there's all like data that we have published, and before you even do a literature review, you do not know that 80% of the people uses internet to before consultation. So we thought that the content shared on this platform does not go under formal standardization or validation. So we thought we looked up other studies that have assessed YouTube content, and we found that there are two criteria that you can use to assess plastic surgery content, which is a modified JAMA and DESAN criteria. So although YouTube is not formally standardized, there has been something that is coming up called YouTube Health. And YouTube Health is dedicated of making high quality health information accessible to everyone. But the fact, I don't know how many new YouTube Health before now, but apparently I did not know about YouTube Health until we all started like searching about YouTube contents. So it has over like 9.5 million uploads, and they have like categories where they do mental health or other health conditions. And there is a total global uploads of mental health for 3 million. So for this YouTube video, you get verified, and you have like kind of a badge or something. So to mention that although YouTube is knows that people go there for information, especially health related information, they have tried to create something else called YouTube Health. I don't know how many people knows about it, but at least they're trying. So we were exempted for an ethical review because this was public information, and we were not using any human like human data or interaction with patients. And second, we did not sought to get funding. What we did was we created a search strategy. So if you look at our paper on the appendix, there are over, if I'm not mistaken, 20 such strategies. And all those such strategies were like we went through YouTube, and then you clear your history, and you set it into one of the African region, and then you download the 50. You extract information from the 55 videos. So Shile will go into details about that. So second is the first speaker mentioned about the funding. So there are a lot of people out there, especially medical students. So what they are looking for is not funding at the moment. So they are looking for experience. And at AfroPRS, we are giving them experience. We now have launched our first research fellowship, and we have, I think, 13 fellows now. So we are just exposing them to systematic reviews, anything that doesn't really involve going to the field, and also getting some of the content that would maybe require an ethical review or maybe require some kind of finances. So I will let Shile go through the methodology and results.
Okay, hi everyone. I will continue with the methodology and the results for this study. Now, this study was a cross-sectional study where we extracted metadata from plastic surgery videos that were posted on YouTube. My co-authors and I came up with a video search strategy where we first came up with a list of keywords. The keywords were 20 in number, and some of these keywords were keloids and hypertrophic scars, breast reconstruction, acute hair, cleft lip and palate, among many others. Now, the browser we used for our search was Google Chrome, and we set our search settings to relevance to replicate what the typical user would see when they type any of these keywords in their search bar. Now, to ensure the effectiveness of our approach, we did a pilot evaluation. This was done by myself and Alice, and we did that on a random sample of 2 videos. This pilot evaluation helped us to identify potential technical issues that came up with our search strategy and evaluation process. And the feedback we got from the pilot was then used to refine our methodology for data extraction as well as the analysis. Next page. Now, for the data analysis, we performed descriptive statistics and we used the Mann-Whitney-U test for bivariable comparisons. Now, for regression analysis, we did ordinal logistics for primary outcomes and beta regression for secondary outcomes. And we set our statistical significance level to 0.05. Next. Now, I mentioned earlier that we started with 20 keywords. So for each keyword, the first 50 video results were logged into our Excel spreadsheet for analysis. And each video was independently assessed using standardized tools. And to ensure consistency, the scores from both reviewers were averaged to resolve any conflicts or discrepancies. We also extracted key metadata from each of the videos, and some of the data we collected were the number of views, number of likes, number of comments, the channel subscribers, the dates the videos were uploaded, the number of views per day that is calculated by using the total views over the number of the video age in days, and also if the video was made right here in Africa. This approach helped us to systematically assess the quality as well as the reach of plastic surgery content that are available on YouTube. Next. Now, we had an inclusion and exclusion criteria for this study. We included all videos that were in English language and videos that were relevant to plastic surgery. And we excluded all duplicates, videos that lack subtitles and audio, as well as videos that were marked as private. Then we categorized our videos into 4 main groups according to their sources. And these main groups were university or professional organizations, medical advertising, independent users, and others like the news and government. Yes. Now, primary outcome measures assess the reliability of these videos. Now, for our study, the tools we used to assess reliability were the modified descent score and the JAMA benchmark criteria. The modified descent score looks at 5 main things. It assesses the clarity of the video, the reliability of the video, bias, reference supplementation, as well as uncertainty. And the highest you can score on this tool is 5. So for a video to have a modified descent score of 5, it means that that video is highly reliable. Now, the next tool is the JAMA benchmark criteria, which evaluates authorship, attribution, disclosure, and currency. Now, authorship ensures that the authors are clearly identified and accountable for their work. Attribution requires proper citation and acknowledgement of the sources. Disclosure looks at the transparency of potential conflicts of interest, funding sources, and any other relevant information pertaining to the work. And currency ensures that the information is up to date, as well as is reflective of the current medical knowledge and practice. So with this tool, the highest you can score here is 4. So if a video has a JAMA score of 4, it means that that video is highly reliable. Now, secondary outcome measure looks at the engagement of the videos. Now, engagement is a key measure of how well your content resonates with your audience. And high-end platforms or big platforms like YouTube tend to prioritize popular posts and help you reach more people organically. So for our study, the metrics we use to assess engagement were the likes to view ratio and the comments to view ratio. Likes to view ratio was calculated using the number of likes over the number of views expressed as a percentage, and the target to be considered engaging was 4%. Comments to view ratio was also calculated using the number of comments over the number of views, also expressed as a percentage, and the target to be considered engaging was 0.5%. Next. Yes, so I mentioned earlier that we started with 20 keywords, and for each keyword, the first 50 video results were logged into our Excel spreadsheet. So that gives us an initial sample size of 1,000 videos. Now we applied our exclusion criteria and we excluded 103 videos. Now a breakdown of the 103 videos, 78 of that were not relevant to plastic surgery. 11 videos were not in English language, 8 videos were duplicates, and 5 videos lacked audio and subtitles, and one of the videos was marked as private. So after all that exclusions, we ended up with 897 videos for our final analysis. Now, the videos had a median duration of 4 minutes and a median view per day of 18.8. Next. Now, I want us to pay attention to this table. Now, 897 videos ended up in our final analysis. Now, in terms of authorship, only 35 videos out of that 897 were made by African entities, and this indicates a lack of local representation. Now, another key thing to note on this table is that majority of the videos, which was 486 videos out of the 897, were made by independent users. This is important to note because YouTube lacks standardization, and this means that anybody can pick up a camera and based on personal experience or a story they've heard, a myth they've heard, they can just make a video and post on YouTube, and this can mislead the public, especially when it comes to life-impacting procedures like plastic surgery. So this really underscores the need to really assess the reliability and quality of plastic surgery videos that are put out there. Now, the next thing to note is that academic videos had 206 videos out of the 897. And this also shows or highlights that institutions like medical schools, teaching hospitals, and any relevant healthcare facility can post more or record sessions and put them on YouTube so that the audience or the general public will have access to wholesome content to consume. Now, when we come to the video analytics, the median duration of the videos was 4 minutes. The median number of views per day was 18.8. A median number of likes was 214, and then the median number of comments was 14, which really shows low engagement on these videos. Next slide, please. Yes, so in terms of quality assessment, we used the modified descent score, which ranges from 1 to 5, with higher scores indicating great reliability. So the videos in our study had a median score of 3 out of 5, with an interquartile range of 2 to 3. And this suggests that overall, the quality of information in these videos were moderate. Most of the videos kind of provided some useful content, but many of them lacked depth, balanced perspectives, as well as proper citations of the medical sources. And also with the interquartile range of 2 to 3, it is clear that a significant number of the videos scored on the lower end, which means that they contained incomplete, biased, and potentially unreliable information. Now, this highlights a very important gap that while plastic surgery videos, plastic surgery content is widely available on YouTube, much of it does not meet the high quality standard. And this underscores the need for better evidence-based educational content to ensure viewers have access to accurate and reliable information. Now, using the JAMA criteria score, which evaluates credibility based on 4 key factors, which I mentioned was the authorship, attribution, disclosure, and currency. The videos had a median JAMA score of 3 out of 4, which shows that most of the videos met 3 out of 4 of the quality criteria. And this indicates a moderate to high level of credibility or reliability. Now, the interquartile range of 2 to 3 here shows that some videos scored lower, but majority still adhered to some reasonable transparency standards, but some still lacked full disclosure of authorship and proper references. And this is to tell us that many of the plastic surgery videos on YouTube provide useful content, sure, but in terms of transparency, there are still some gaps that are in there. Now, African videos and medical advertising videos performed poorly in terms of reliability, and this was due to the lack of evidence-based content in these videos. Next page. Now, we come to engagement, the engagement metrics. So for the median likes to view ratio, with our study, we got 0.8%, which was below the target 4%. And then the median comments to view ratio was also 0.1%, which was also far from the 0.5% benchmark. So this really indicates that these videos were not really engaged on. Now, independent videos on their own, in terms of reliability, performed poorly. But when it came to engagement, these videos were really engaged on. It had high audience interaction. And even though the content or the information in these videos were not very reliable, these videos were really engaged on. And academic videos also performed poorly in terms of engagement. And this was probably due to how didactic these videos tend to be. So I was thinking these academic videos can adapt strategies like storytelling so that people watching these videos can sit through and enjoy whatever they're watching rather than listen to like a long 2-hour lecture with a lot of medical terms and things that they cannot really relate and understand. So yes, I'll end here and Alice will continue. Thank you.
Thank you so much. So I think like with our sample size, we have a certain kind of right to comment on that, and also give a certain kind of discussion, and also like our like long-term plan to match the gap. So within the reliability gap, so there was a suboptimal for African and medical videos due to lack of evidence-based content and proper citation. So the tools that we used required that you own the work and also you cite it and also give uncertainty. So most of the uploaded videos that they have, or even most of the presentation that we do in class, especially that's medical or medical like videos that are posted on YouTube, do not have that kind of component. So we do not show references, or we do not show our uncertainty, and we do not show like where can you get further information. So when you post that on YouTube and with the scores that you use, then we found them not reliable. So for the engagement challenges, so independent videos, they were engaging, but they were also at the sacrifice of reliability for popularity. So you would find from the first speaker, he also mentioned that there are like independent people that post a lot about global surgery. So I think this with social media and the influencers, they keep posting like on an individual basis, but you sacrifice like a lot of information to make it a little bit attractive, a little bit short, and then there are some sacrifices that you do within the videos that would make it popular but less reliable. So only a fraction of videos met our thresholds, and this highlight limited audience interaction and also satisfaction. So as an outcome of our research and as an outcome of what we have found to be like the engagement challenge, I think if how these videos are produced or how these videos are uploaded, then you like you like have a limited kind of audience interaction, maybe due to how long your video was, maybe due to how short it was, maybe due to it lacks some kind of information, or even like a culture sense of African of not commenting to like a video or like even liking it, which is I think which is totally different from the Western culture where people comment and then discuss within the comment section and like. So if you would go now to you take to different accounts like Randy's account, like maybe an influencer in Rwanda, then the one in the US, then you'd find that the way they interact through comments and likes is totally different, probably from a cultural perspective. I don't know, that's a gap. So there has been a disconnection between video content and also the interest of African viewers seeking plastic surgery content, and also underrepresentation of African authors and institution also really limited the culture relevant content. So imagine if you wanted to do liposuction in what, because now we have it in Rwanda and it's done in the military hospital. So you want to do that, and you go to YouTube, you find a Mayo Clinic video about on liposuction. So I don't think that would totally be a copy of what you find on the ground in the military hospital in Rwanda. So it's totally different. So those kind of limitations that are cultural relevant also limited the interaction, and also it was one of the underlying causes that we have identified. So what are our recommendations? So we want to improve reliability and credibility, and we wanted that African content creators corroborates, and we encourage that there should be a connection between African plastic surgeon, academic institution, media professionals. So the same way you, as maybe a journalist, take time to go and investigate a war, I think it will be a same way that they should now come to investigate or showcase what is happening in the health system. So to some extent, there's a study that we did before this with others about if people knew that there were plastic surgery or I mean neurosurgery in their country, and you'll be amazed by the Rwandan response, because in Rwanda we got I was able to manage to correct about like 200 people that would be commenting, and these were non-health related, not medical doctors, not nurses, anything related. So they were just like citizens that are not part of that. And I would get comments, they were like, I don't even understand what is neurosurgery. I don't even understand uh, like what did they do? Do we even have those people? I thought they were in the US. So those are the comments that I got. And if people do not know, they will not come to you. So, and if they don't know, even the health related behaviors will change. Even the like the delays in seeking care will be increasing. So we are encouraging African content creators to partner with Africa and plastic surgeon, academic institution, media, to just showcase what is there, the outcome, the whole process within our content and in our culture. So the second one is to focus on quality. So simplify medical jargons, where like as she was mentioning, there is a didactic where we are taught and the lectures are just uploaded without any edit. So we wanted also to simplify that and also provide evidence-based content with proper citation. So I would advise that going forward, even if you get to move further for more content rather than restricting to what you just did. So enhancing engagement. So let's first social media trends. The first speaker talked about hashtags, and I think if you are a content maybe a social media person, you know about hashtags and also
how people will tell you comment, well, you comment this one and then I'll send you this. So those are just trends that are there, but we lack that kind of skills to leverage it within the health system. So, and also let's steer this to the audience needs. So we have a trend. If you observe, we have a trend. We are coming out of COVID, and now information is totally different. So anyone could go and then give false information. So in one way, that's first mark, that's now only like high institution could comment, and we didn't see like
Alice.
influencers and other commenting about that. So we want to we are proposing that we tailor like content through different trends that are happening, and also coming up with what you think is right. So we have seen this in the
Dr. Matomi,
where people just
can you hear me?
keeps giving you information every day and keeps getting updated.
Dr. Alice, we can't hear you.
Education and trust. So create videos that address popular topics in plastic surgery with visual demonstration, the same techniques that influencers use.
I
suspect she also cannot hear us.
Skills within the health system. So and also balance accuracy with engagement by including real-world stories
Alice.
and surgical outcomes with consent. So if you look at the kind of videos that we have, so there might be maybe a Botox from a patient and they're from a certain private clinic.
Okay. Alice, we can't hear you. We'll try and message her until she can. In the meantime, what I will do, just quickly while we take this hiatus, is I will just ask everyone who's here to start thinking of your questions. So we will start a discussion shortly. If you will do that. And also in this moment, I will just ask you to fill in a really quick survey if and when you get a second, just while we let Alice reset.
Alice, can you hear us now? Alice? No.
Maybe if you stop the screen sharing, she'll be able to see that something's going on, because once the screen is being shared, she may not see anything else. Can you try that?
Alice, can you hear us? Alice, can you hear us now?
We can have questions.
Oh, hi, Alice. Your last maybe 5 minutes, we couldn't hear you, and I don't think you could hear us. Your sound is,
because I can't hear you.
yeah, you were because your sound is very hard to hear. Even now, it's very difficult. So we got most of what you said, but it was the last 5 minutes that was a problem. But I think, should we just go to questions at this point? Because I think we're having some technical difficulties. Should we, maybe if we all turn our videos off, sometimes that helps.
Can you hear me now?
I think you're still a little unclear. hopefully it will clear up with time. We can probably get started with questions. And if you are able to hear us, hopefully we can let you know if the sound improves or if it's still a little crackly. So I'm happy to ask the first question, and I will ask it to all of our speakers here. And that is just, I guess, the most obvious question, but really, I suppose in this, social media is very topical at the moment, and
Hi, can you hear me now?
You're still a little unclear. So I suppose social media is very topical at the moment, and as we know, we're seeing a lot of change in the way that we are getting. We're seeing a lot of changes in the kinds of content that's going to be allowed out on social media platforms. And in doing so, social media platforms are obviously acquiring quite a lot of power. At the same time, it seems that they are alienating quite a large group of people who are now moving away from social media. So sort of a strange dichotomy, which I guess we're seeing in or power imbalance. And I guess like with that in mind, where do you see the role of social media going forward, particularly at the moment, but definitely over the next sort of 5 years or so? And do we think advocacy, social global surgery, sort of intellectual discussion, that all still belong on those platforms? Or will there be sort of a new wave of change coming through as well? And a question to all of our speakers and also, I suppose, to our audience, if anyone has anything they'd like to say to that.
Afra, I think that's a great question and something I've been pondering myself, especially as we see the trends in social media with certain speakers increase in terms of visibility and differences from a regional perspective as well. We saw, for example, Instagram be turned off in Turkey or Turkey. We also, we've seen TikTok be blocked in the United States for that matter. And so I think one of the things that's really important is networks and partnerships, and that, for example, Globe Surge Africa or Surge Africa or COSEXA, I think these partnerships and relationships that we have are going to be really important to mitigating disinformation and misinformation across these social media platforms and sharing information. And I also think that there are also other ways of sharing information, WhatsApp, WeChat, and so maybe it's going to be, we'll go back to, I don't know, maybe we'll go back to the old days where we had one-on-one conversations or group conversations, or maybe webinars and seminars. These are hopefully important areas of sharing information. But I think misinformation and disinformation, those are going to be important areas to address as we try to preserve global health and global surgery, because I think that's a key concern. And especially ensuring that we don't become an echo chamber as well. So those are the things that are topical for me, but I would be interested in others' thoughts too.
Yeah, what we'll do is just again, I think Alice's internet still isn't being favorable. So definitely, I don't know if Shirley, you have any comments to add to that. But if not, then I'll move on to the next question.
No comments to that. You can move on.
So I guess a question from Patricia. I don't know, Patricia, if you would like to come online and ask your question. And I guess I'll ask it for you. So Patricia is asking, I'm curious as to know how the research team selected the 20 keywords for the search and the number 50 for the video selected for the study for each keyword. So Alice, if you're able to hear us and if your internet is favorable, it'd be great to hear from you. Otherwise, Shirley, I wonder if you'll be able to answer that.
I can go ahead. So we selected 20 keywords, words that are specific or very relevant to plastic surgery. So some of them were keloids and hypertrophic scars, breast reconstruction, like words that are mostly searched on the internet. And we came up with 20, not because 20 is a special number, but that was what we could manage in terms of the data to make sure our work is very accurate. And for each keyword as well, for each keyword, the first 50 video results. So once you type in let's say we type in keloids, the first 50 video results that pops down, that is what we copy the link and put in our Excel spreadsheet for the analysis. So there wasn't any special reason why we selected 20 or 50, but that was just the number of data we could handle for the study. I don't know if that answers the question.
Can I add something? I'm audible now.
Okay.
Yes, and your sound is excellent. Thank you so much.
I'm so sorry for what happened. I really don't know. And so for the 20, we had a team of 15 people. And if you wanted to go beyond 20, then we would have come up with 1,000 videos, which would have taken us a long time, because if we started this study, I think like in July, and we were able to finish it in November. So for the sake of time, we just limited to like what Chile said. What are the most researched question on Google? So you come up with cleft surgery, you come up with burn, gynecomastia, you come up with BBL and others to mention. So we just contained our work within what was most researched about. But if you want to take this further, then you can go ahead and search other keywords to see if the data will be the same. So, and what we are now trying to do is we are trying to form this into a qualitative study, where we now want to hear African like viewers their own views about what they see on YouTube. So I think this will increase the credibility of the research, and also if we really find that they are mostly exposed to Western media or Western uploads, then we will know that we can again tailor our recommendation to see how African content, and also in a collaboration that I don't know if you heard about that, but in a collaboration where we can find people to like to corroborate and then bring news media or radio something to start talking about plastic surgery. Thank you so much.
Adeline, I can see you have your hand up. Would you like to ask your question? Okay. If not, we'll come back to Adeline in a minute. Christina, I think I could see you asked a really nice question in the chat as well. I don't know if you wanted to ask yours.
Yes, of course. Thank you so much. Thank you so much for this platform. It has been very, very interesting. My question is for Dr. Navarro. I want to know your opinion. Do you think if you guys expanded the languages, probably 3 or 4, do you think that the results will follow the same pattern that you show us, or do you think that they will change? And if so, what factors do you think that they could change those results?
Christina, thank you so much for that question. I think that's a terrific question and a wonderful thought process. And this is something that we contemplated as we were designing this study. I certainly do think that our use of the English language influenced the results and biased them towards English language speaking countries. And so a simple Google search of English speaking countries and distribution globally can show you that we probably missed a subset of the global distribution of global surgery for large portions of the world, and that includes Southeast Asia, East Asia, South America, Central America, as well as parts of the Middle East and Eastern EMEA. So I would love to see somebody update this analysis, potentially for with the new technologies and analytics that we have for a range of languages, as well as understanding what the new trends in SOMI surgery are. So I think that's a terrific question and an excellent idea.
Amazing. Adeline, I wonder if your audio is working again, if you'd like to ask your question. No, maybe still not working. Mina, I could see that you had a question.
Yes, I was just wondering how the situation is in Rwanda, how the staff overlaps between plastic aesthetic and plastic reconstructive surgery, whether it's rather separate, distinct, or whether it overlaps.
Thank you so much. So it depends. So we now have 5 plastic surgeons in the country. So from 2010, that's when we had our first plastic surgeon, and then we the second year a second one came in, and now they started a residency program. So it often overlaps, but the question is, so now you have to have a straight line between what is cosmetic and what is reconstruction, because plastic surgery generally involve both, but to some extent it is separated, because now most of the cosmetic products are just 100%. You just pay out of pocket 100%, but for the reconstruction, if you want burn, if you have gynecomastia, if you have like any other condition that does impair your functioning, then it turns into reconstruction, and the insurance-based, that the community-based insurance program that we have covers that. But we have seen a rise of people going for like breast reduction. We have seen people going now for liposuction, because we have at the moment, I don't know if you know the geography of Rwanda, but we have 2 hospitals that can do that. We have King Faisal and Rwanda, and also the Rwanda Military Hospital that can do both cosmetic and also reconstruction. But we add like Seashika, which is fully a reconstruction site. So I don't know if I answer your question, but basically that they overlap oftenly, but you have to know if the insurance is paying that or not. If it doesn't pay that, then you are considered cosmetic.
Thank you.
Amazing. Pirette, I can see that you have a set of questions. Would you want to ask them?
Yes, thanks, Afra. Thank you to all the speakers for great presentations. So my question goes to Shelley and Alice. From their research, there was clearly one of their recommendation was to involve plastic surgeons to produce reliable content. But from their results, there was clearly a poor engagement from the academic videos. So I just wanted to know the strategies they intend to use for these academicians to produce engaged videos, but also that are reliable. Thank you. Over.
Let me just touch on that a bit, and then I will let Shirley complement. So I think like you're among the people that are changing the paradigm, if I might say so. So you are now a physician, but you have like real life storytelling podcast from patients. So that is one way, right? So if I wanted to hear like the whole process of surgery in Rwanda and barriers that people face, I would go to your podcast. Right. So you started really doing that, and we are also we stand you. So I think like in terms of uploading a video now, that's where the challenge comes, because we want to just download something that now we have done a static, and then we want to upload it. We cannot even at least have it into parts, like maybe the outcomes separately, the risk factor separately, and then we add some kind of a discussion point or some kind of human interaction. So I think it is time that we start to involve a little bit of creativity and also learn from influencers. So we mentioned about a collaboration. So we would want to see uh, influencers, or we would, either party can reach out to each other, but we would want them to have that kind of collaboration where, like, even if it's an interview, why can't we hold like a video podcast on bands in Rwanda? I have, like, I don't know, we have done like 3 studies on bands in Rwanda, and I would now comment about bands because I have done the research. So if we were to have a podcast, then I will give you the scientific evidence of ban in Rwanda. But I need a patient who went through that. So we want that kind of collaboration, not only inviting specialists or physicians that have a statistical evidence, but we want also a real life evidence into this so that people can relate, so that it can be culturally sensitive and also involving. So I will let Shirley add her comments if possible.
Okay. So with YouTube videos, one main thing is you have to really put efforts in the production or the video you're putting out there, like creating eye-catching thumbnails, like using interesting video titles to make sure when someone sees the video like on YouTube, they are eager to click and watch it. And also we should adapt some storytelling ways. There is this Nigerian content creator. He's a medical doctor. He's called Chinonso or something like that. I'm not sure of his name, but the way he tells his health stories are really catchy. And even someone who has zero idea about medicine in any sort, in any form, can relate to that and want to listen and want to take whatever he is talking about. So I think it's really important that we, instead of using the normal boring way of communicating our stuff to the general public, we can adapt more fun ways to make the content really interesting, so that whoever clicks on it and watch would really stay through. And also at the end of the videos, we should like create like thought-provoking questions where we encourage people to drop some comments, share their opinions on certain thought-provoking questions, so that will also boost the engagement as well. So those are the things I think can improve engagement. Thank you.
Alice, I think if you want to respond as well.
No, there's a question in the comments that Dr. Murugeta mentioned, that do we recommend that we need to check reliability of some videos before watching it? So unless you have the scores in your like you actively record the scores, then you would support that this video is not reliable. But for the public, the general public, I don't think they have the ability to check for reliability. But what we can do is to advocate that now YouTube start to have like credentialed badges. I think some of the accounts now have that, where they know that now content from this creator is reliable. Other than that, it will be a lot of work. So I don't think that we are there yet. So to know the reliability, but what we can do as physicians, we can start anything that we upload from academic institution or even our own accounts. Then we should be able to add some references. We should be able to go to just get out of our scopes and then let people have the opportunity to go beyond what you have just said. So I think that will be helpful.
I think what we'll do is we're going to start wrapping up soon. So if people have final questions, we probably have time for just one or two more. I know that Adeline has a hand up, so I'll let her ask hers. And then we'll see if there's time for one more after that. Adlin, is your audio working again? Maybe not.
She has left.
Oh, okay. So that's fine. So I guess what I will do is I will just I mean I could see one more good question actually from Sergio, which I thought was a great question. I don't know if you want to ask it yourself, Dr. Navarro. If not, I can ask it for you.
Absolutely. So Dr. Matoni and Dr. Dadson, how do you think that generative AI and platforms like Sora could help with content creation that's culturally specific, specific to either regional patient needs or to cultural considerations for engagement?
Shay, do you want to start?
Okay. I think AI can definitely help with content creation in the sense that it can help you like gather your thoughts, plan out your videos even before you make them. But also if you rely on it solely, it reduces or it removes that human touch from it, and it's difficult for the viewers to really connect and relate to it. So even though it can help, it shouldn't be relied on it solely for content creation. That's my thoughts on it.
Yeah, to add up on that, I think AI has certain kind of limitation, but also it can be widely used. In this case, if I am a physician and I don't like to record my voice, I can use a voiceover from AI to explain that if I'm using especially English. But we have been emphasizing on cultural context, then we have to upload some Kinyarwanda, I don't know, videos, but or some Swahili videos. So to some extent, AI mispronounce some words, but can also be helpful. And I don't know, there is a, if probably I'm biased, but there is a like a subconsciousness when I see an AI video that I turned out not to be like real or something like that, and then I skip. But to some extent, people will get used to AI and they will start to adopt it. But at the moment, we have to involve a human part. Either you don't want to show your voice, then you use voice over, or you don't want to show your face, maybe use an AI creation tool, your emoji or something like that. But in either way, as Sheila was mentioning, AI really does a nice job in aligning your like all your scripts, and you can use that. And also, in terms of one of the concerns in our journal club was that we don't have time, so AI can be your assistant to just keep doing these videos as fast as you can. Thank you so much.
Amazing. Well, I will say that I've really enjoyed this discussion today. I think it's been really nice to hear from everyone. And again, I think a really topical conversation to be had. We at the Paul Farmer Collaborative are thinking about ways that we can actually continue discussions like this online, and what platforms we should be using to do that. So if anyone here has suggestions about how we can do that, like please let us know. And one of the ways you can do that is by filling in our feedback form, which I've just posted in the chat there. So please take the time to do that if you have a moment. It's just 1 minute's worth of questions, and it would be hugely appreciated. I will say thank you once again to our speakers. Again, like it's just been lovely having you, and a really interesting discussion. And I will also say thank you to our audience for tuning in today. We know that you come from all over the world and make time to be here, so it's very, very much appreciated. And we are really excited to see you at our next seminar, which will be the second week of March, and we'll send out details about our speakers and what topics we're hoping to discuss around then. And the last thing I'll do before I sign off is just show us the results of our Menti poll, which have just come through. And just again to say thank you so much for all of our participants from all over the world. It's always nice to have a global discussion on global surgery. And we were very glad to have you. And I'm looking really forward to seeing you all again next time. So thank you very much for your time, and I will see you in March.
Hi, all. Thank you. Love the conversation.
Thank you.
Thanks, everyone.
Thank you so much.
Thank you.